PCOS, what are my treatment options? This is part one, where I'm going to talk about targeting testosterone and how we use estrogen and progestin. So treatment for PCOS is aimed at what is important to you and for you. In part one, I will talk about directly targeting elevated testosterone and treatment with estrogen and progestin. In part two, I will talk about addressing insulin resistance. And in part three, I will talk about other ways to address individual symptoms. So here we go, part one. I am going to talk about prescription medicines, which are drugs that are potentially harmful if not used under the supervision of a licensed healthcare provider. So this is just an overview of some of the uses and potential harms of prescription medicines, but you and your provider can best determine what is appropriate and safe for you. There are three ways that we can decrease the effects of testosterone. And remember, testosterone is one of the main reasons for all of the symptoms that we see. We can lower production, we can bind any testosterone that's floating around, or we can block testosterone's action. So to decrease the production, we can use treatments with both estrogen and progestin, or treatments that lower insulin. That will be the next talk. Second, we can increase the protein that binds it, the sex hormone binding globulin. This can be accomplished using treatments with estrogen taken by mouth and treatments that lower insulin. And third, we can block the testosterone receptor. This can be done using a medicine called Spironolactone or a combination oral contraceptive pill that contains a specific kind of progestin called progesterone. So let's first talk about spironolactone. This is a prescription medicine. It is considered to be something called an aldosterone antagonist with anti-androgenic properties. What does this mean? Basically, the aldosterone antagonist fancy part just means that it's a weak diuretic, which is a water pill, and has been used to reduce fluid buildup that it can be seen in heart failure, high blood pressure, and swelling. It is a pretty weak water pill and is generally not used very much for this indication anymore. It is often used for its anti-androgenic properties, which is the testosterone receptor blocker action. So because it has this action, it is used to treat acne, scalp hair loss, or unwanted facial and body hair that is related to elevated testosterone. There's a pretty wide dose range. Some you can prescribe as low as 25 milligrams per day and as high as 200 milligrams per day. This cannot be taken in pregnancy because normal male genital development depends on testosterone. For this reason, some prescribers will make sure that you're on birth control. And at higher doses, because it is this water pill, it can cause thirst or increase in urination and worsening dehydration, which can also make you dizzy going from sitting to standing. In high-risk people, it can cause high potassium, and other side effects include breast tenderness, feeling tired, nausea, menstrual spotting, or headaches. Next, estrogen progestin therapy by mouth. Combination oral contraceptive pill, which is abbreviated by some as COCP, is also a prescription medicine. It's combination because it contains both estrogen and a type of progesterone called progestin. So each pill in the first 3 weeks of a 4-week pack contains both estrogen and a progestin. That's seen here in blue. The estrogen component builds up the uterine lining, causes the liver to make more of this binding protein, and higher levels are more anti-androgenic or anti-testosterone. The progestin component has an impact on the uterus. It keeps the lining from shedding too soon, prevents the lining from growing abnormally. It thickens the mucus at the entrance to the uterus, preventing sperm from entering. If the progestin is drospirenone, which is seen in Yaz and Yasmin, this blocks the testosterone receptor similar to the way that spironolactone does that we just talked about. Some progestins are more androgenic than others, so they have a little overlap and may actually sort of act like a testosterone-like hormone. In PCOS, as we've talked about, the LH and FSH are released from the brain, sometimes the LH more than the FSH, which causes the ovary to make estrogen and progesterone and release an egg, but also produce testosterone and new cysts. So when the PCOS is treated with a combined oral contraceptive pill, when the brain detects the estrogen and progestin, it stops sending the LH and the FSH because it thinks, oh, I already have it. So then what happens is the ovaries go into a resting state. If they're in a resting state, then they're not going to do any of these things, make testosterone, release an egg, or develop new cysts. A thin endometrial lining is built up, that's the lining of the uterus, and maintained during the 3 weeks of hormone pills, and then shed during the placebo week. So that is when you get your period. If there's a reason to not have monthly periods, some packs come with 12 weeks of hormone pills and 1 week of placebo. There are risks of these. So most of them are related to when estrogen is taken in the form of a pill because it gets digested, has to go through the liver. So it is usually not recommended if you have a blood clotting disorder, if you have elevated blood pressure, if you have severe migraines with an aura, which is when you see or hear things around the time of a headache, a liver tumor, or open growth plates. One type of progestin, Spironolactone, was not used for years due to reported increased clotting risk. That risk has subsequently been determined to be present but minimal. The benefits of using oral contraceptives with this type of progestin in PCOS are believed by many to outweigh any risks. So just as an example, if you don't have a clotting disorder, but you have PCOS, your risk of developing a clot in 1 year is about 0.06% and increases only slightly with the Spironolactone containing OCP to 0.1%. There are different doses of estrogen between 10 and 30 micrograms, and there are different types and doses of progestins, all of which have different degrees of androgenicity. So in general, lower estrogen doses may be safer for conditions like migraines, but downside is you might have more breakthrough bleeding, which is like spotting when you don't expect it, and there's less anti-androgenic effect. The less androgenic progestins are, in general, better for mood, your cholesterol levels, and are more weight neutral, but they may increase your risk of clots. There are hundreds of different types of OCPs, is the bottom line. And if one type doesn't work for you, another type might. So is there a way of taking estrogen and progestin that is not by mouth? There is. So there is an estrogen and progestin patch, and there is also a vaginal ring that contains both estrogen and progestin. These will have the same effect on the ovary in that they lower the testosterone and prevent ovulation and new cyst development. And they will not increase your clotting risk like taking the estrogen by mouth. What about progestin-only therapy? I get this question a lot. So there are progestin-only methods, and how good are they if you have PCOS? So this includes an IUD, the depot injections, an implant, the Norplant. These are all prescription medicines and are often used for contraception. There is another medicine called the O pill, which is a non-prescription medicine and just contains oral progesterone. So treatments that use progestin without estrogen do not interfere with testosterone production or binding. So they are less helpful in PCOS. They can still be used for birth control and for uterine health. If progestin is used without estrogen, it does not significantly increase the binding protein or consistently put the ovary to sleep, so you may still get cysts. It does control the timing of the shedding or withdrawal bleed and prevent the uterine lining from growing abnormally, which decreases the risk of cancer over the long term. It will also thicken the mucus at the entrance to the uterus, preventing sperm from entering, which is why it is used as birth control. There's something else called a progesterone withdrawal. This is also prescription and is used to decrease the uterine cancer risk and to keep the uterus healthy in those with infrequent or absent periods. So a 5 to 10 days of progestin-only pill will cause a withdrawal bleed or a period within a week of stopping and can be used to treat infrequent periods in people who are not taking estrogen. This has no contraceptive effect. This is just a summary of all of the different types of estrogen and progestin that can be taken, as well as where spironolactone fits in. The next thing that I will talk about in the next video is addressing insulin resistance.